Today, we are on site at McCormick Place in Chicago at the 2019 ASCO annual meeting. We'll be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Bradley Monk on data being presented in ovarian cancer and Dr. Robert Ferris on the practice-changing head and neck cancer studies. Welcome to OncLive News Network. I'm Gina Columbus. In breast cancer, updated results of the phase 3 MONALEESA-7 trial demonstrated an improvement in overall survival with the CDK4/6 inhibitor ribociclib combined with endocrine therapy over placebo and endocrine therapy in pre- or perimenopausal women with hormone receptor positive, HER2-negative advanced breast cancer. The estimated OS rate was 70.2% at 42 months with ribociclib and endocrine therapy, compared with 46.0% with endocrine therapy alone. This represented a 29% reduction in the risk of death with the addition of the CDK4/6 inhibitor to endocrine therapy. Five-year follow-up from the KEYNOTE-001 trial showed that the 5-year overall survival rate of newly diagnosed patients with advanced non-small cell lung cancer who received single-agent pembrolizumab was 23.2%. Previously treated patients had an OS rate of 15.5%. These data compared favorably to historical pre-immunotherapy OS rates of approximately 5%. The phase 1b KEYNOTE-001 trial was the first study ever to evaluate the PD-1 inhibitor in patients with advanced NSCLC, and these results represent the longest safety and efficacy data presented for patients with NSCLC treated with pembrolizumab. Also, in gastric or gastroesophageal junction cancer, frontline pembrolizumab was found to be non-inferior in regard to overall survival versus standard chemotherapy among patients with PD-L1 positive, HER2-negative advanced disease in the phase 3 KEYNOTE-062 trial. There was a clinically meaningful improvement in OS with pembrolizumab among patients with tumors that had high levels of PD-L1 expression. 39% of patients in this subgroup were alive at 2 years versus 22% of those on standard chemotherapy. Monotherapy with lurbinectedin as a single agent was found to have clinical activity in the second-line setting for patients with resistant and sensitive small cell lung cancer. Moreover, there was also an acceptable and manageable safety profile with the therapy, which is administered once every 3 weeks. These data could demonstrate a new promising agent for this patient population, which is an unmet clinical need. In prostate cancer, the addition of apalutamide to androgen deprivation therapy led to an improvement in radiographic progression-free survival and overall survival in patients with metastatic castration-sensitive prostate cancer in the phase 3 TITAN trial. The benefit was observed in patients with high and low volume disease and whether or not they had received prior docetaxel treatment. The safety profile was also found to be manageable. In the double-blind, randomized phase 3 EORTC 18071 study, a 6.9-year median follow-up showed that 10 milligram per kilogram of adjuvant ipilimumab was associated with a sustained improvement in relapse-free survival, distant metastasis-free survival, and overall survival in patients with high-risk stage 3 melanoma. The CTLA-4 inhibitor has been approved by the FDA in this patient population since 2015. For a full review of all of these studies, please visit OncLive.com. Here now to expand on a handful of ovarian cancer abstracts here at the 2019 ASCO annual meeting is Dr. Bradley Monk, who is the professor and director of the Division of Gynecologic Oncology at Creighton University School of Medicine at St. Joseph's Hospital and Medical Center, Arizona Oncology. Hi, Dr. Monk. We're so happy to have you here today.
Gina, thank you. It's great to be with you again, and I'm so excited about what we're doing in gynecologic cancer, most importantly with targeted therapies.
So let's talk a little bit about that. So we're here at ASCO. What are you most excited about of the intriguing data that's coming out of this year's meeting?
So most importantly, we have the study SOLO-3. So of course we had SOLO-2, which was platinum sensitive maintenance olaparib, and then SOLO-1, which just came out in the New England Journal in December, FDA approved December 19th, maintenance frontline in BRCA mutated patients. But everyone wanted to know, is a PARP inhibitor, olaparib, as good or even better than chemotherapy? So presented at this meeting is Solo 3. And Solo 3 is a head-to-head comparison of olaparib versus chemotherapy. And finally, we proved the naysayers wrong that olaparib is better than chemotherapy in BRCA-mutated patients. So that's really transformational, because the provider had to, do I want to use a PARP inhibitor or chemotherapy? Chemotherapy works well in BRCA-mutated patients. Well, now we've proved it. PARP inhibitors, particularly olaparib, is superior to chemotherapy. So I'm very excited about that. I think that's going to lead to another FDA approval. That'll be the 7th FDA approval of a PARP inhibitor in ovarian cancer.
Very cool. So what about some other trials here? So we have niraparib that's being looked at in combination with bevacizumab in recurrent platinum-sensitive ovarian cancer. So what's the significance of this study? What do we expect to see maybe?
So as we get more savvy with targeted therapies, we want to add them together. And as we add targeted therapies together, we want them to be instead of chemotherapy. And I already told you, olaparib beat chemotherapy. So how about a chemotherapy-free regimen in platinum-sensitive relapse? So there's a randomized phase 2 of niraparib, PARP inhibitor, versus niraparib and bevacizumab, a humanized monoclonal antibody against vascular endothelial growth factor. And that doublet, niraparib bevacizumab, was amazing. Looked exactly like chemotherapy, what we're accustomed to in platinum-sensitive relapsed ovarian cancer, and certainly beat niraparib alone. And importantly, it was most active in the non-BRCA patients. So I already said if you have a BRCA mutation, a PARP inhibitor is better than chemotherapy. But how do we advance the field in non-BRCA patients? Combinations. And this study, it's a preliminary, it's a randomized phase 2, but it's a proof of concept that combination, in this case niraparib and bevacizumab, really performed at the level that we would expect in the BRCA-negative patients of chemotherapy, and certainly was better than a PARP inhibitor alone. BRCA-mutated patients, maybe a PARP inhibitor alone is sufficient.
Now, what about also in ovarian cancer? Any other intriguing data that we're seeing in ovarian cancer with PARP inhibitors?
So we're really looking towards ESMO. So at ESMO we have, I think, 3 randomized phase 3 trials moving PARP inhibitors into frontline in an expanded opportunity. So I already told you that Solo 1 is fantastic, hazard ratio of 0.30, 36-month improvement in progression-free survival frontline, FDA approved December 19th, but only in BRCA patients. So how about all the other patients? So PRIMA is a Tesaro-sponsored trial looking at frontline initially in those with BRCA-like molecular signature, but ultimately in all comers. And then maybe bevacizumab and a PARP inhibitor together, because I already told you we had a proof of principle in platinum-sensitive relapsed. So this trial called Paola-1, also probably to be presented at ESMO, takes frontline chemotherapy, bevacizumab maintenance, FDA approved June 13th last year, frontline bevacizumab, and adds olaparib in the maintenance setting to all comers. So again, it's, I think, current standard of care to use PARP maintenance in the BRCA cohort, but we want to expand that either with single agent PARP, PRIMA, or with bevacizumab, olaparib, Paola-1. So again, we're trying to expand the opportunity, and really for you guys, to give you guys more opportunities. You already have bev in all comers, olaparib in BRCA mutated patients, but what about BRCA non-mutated patients or the combination of PARP and bev? So ESMO is going to be fantastic. I hope we can do this again. You have to come to Barcelona, and we'll see you then.
And a quick thing too about, what about beyond ovarian cancer too? So any other gynecologic malignancies here at ASCO or looking ahead at ESMO?
Thank you. So we have 2 FDA approvals, recent, of targeted therapy, pembrolizumab and PD-L1 positive second-line cervix. And then we also have MSI-high pembrolizumab in recurrent endometrial cancer. And then, of course, we have bevacizumab in cervical cancer with chemotherapy frontline. So we got bevacizumab, pembrolizumab twice. So both cervix and endometrial cancer have targeted therapies. But I had a trial in progress abstract here, which I'm most excited about. is that despite all of these approvals and indications, we're not curing more patients. And the most common gynecologic cancer around the world is cervical cancer, and despite vaccination and screening. So our vision, my vision, is to add immune therapy to chemotherapy and radiation in those locally advanced cancers and try to find more cures. And so that study is called CALLA, C-A-L-L-A. Takes locally advanced cervical cancer, which the standard treatment is chemotherapy and radiation, and layers on top of that durvalumab, monoclonal antibody against PD-L1. So that's probably, moving forward, will be the ultimate challenge to cure more cervical cancer patients. We'll continue to make incremental benefits, but that's what I'm most excited about, is the opportunity to cure more patients.
Awesome. Well, Dr. Monk, thank you so much for joining us here today. It was wonderful, and maybe I will see you in Barcelona. Who knows?
I will see you in Spain. Thank you.
All right, thank you. Next, we are here with Dr. Robert Ferris, who's the director of the University of Pittsburgh Hillman Cancer Center, to discuss the latest in head and neck cancer treatment. Welcome, Dr. Ferris. We're so happy to have you here today.
Thank you, Gina. Glad to be here.
Oh, thanks. So, this year, we're seeing overall survival results of pembrolizumab as a single agent and in combination with chemotherapy in recurrent head and neck cancer. So what is the significance of these data?
So previously we've seen activity of pembrolizumab and nivolumab in second-line recurrent metastatic head and neck cancer. This is the first positive phase 3 trial in an earlier line of therapy, first-line recurrent metastatic head and neck cancer, where the standard of care, the only approved regimen, is 3 drugs, platinum, 5-FU, and cetuximab, so-called extreme regimen. And so pembrolizumab monotherapy went up against extreme, and then a third arm had pembrolizumab integrated into extreme, replacing cetuximab. So 3 arms, about 800 patients, a positive phase 3 trial. Both arms beat extreme, the kind of current control arm, standard of care. Slightly differently, monotherapy, pembrolizumab, was better only in the PD-L1 positives. Merck does it with a combined positive score, the CPS 1 or greater. All comers, the entire population, did better when you added pembrolizumab to chemotherapy. So 85% of the population is PD-L1 positive or CPS 1 or higher, and can then get pembro monotherapy. In situations where the oncology team feels like the patient needs to have a more rapid tumor shrinkage response, you might use the chemo, platinum 5-FU plus pembro. That had a better response rate, about 35%, whereas pembro monotherapy had a response rate of about 19%. So an earlier response, but the durability in terms of better overall survival came in either arm that contained pembrolizumab. So it's helpful, moves the field one step earlier in disease for IO therapy, and now shows that you can combine with chemotherapy and still get durable benefit.
Great. So you were also involved on a study in which safety and disease control were achieved with adding nivolumab to chemoradiotherapy in patients with intermediate or high risk local regionally advanced head and neck cancer. So could you also discuss this study?
Sure. In the same theme and philosophy of moving immunotherapy earlier into disease, this is now in the locally advanced, previously untreated stage, where patients who have a survival that's still not optimal. The high-risk HPV negatives have about a 45% 2-year progression-free survival. The intermediate risk, which is the HPV positive, but smokers with heavy tumor burden, have about a 60% 2-year progression-free survival. So still room to improve. And so in the context of a so-called intensification with immunotherapy using nivolumab, this is the RTOG 3504, and we showed safety and durability by adding immunotherapy on top of the standard cisplatin chemo plus radiation, which has some efficacy but really not optimal. And we want to ask whether immunotherapy is safe, which it is, and then does it have better oncologic benefits. It's a small trial, but it sort of previews some of the phase 3 trials that are now running to show oncologic efficacy and hopefully get FDA approval for adding immunotherapy as this intensification. And it's intensification, and yet it's still very, very tolerable.
Good. It's very interesting. Now, we've seen a lot of headway made with immunotherapy in head and neck cancer, but what about any kind of work that's being done with more targeted agents, cetuximab, or maybe any others that are in the pipeline?
So cetuximab was compared to chemoradiation and was shown to have a worse outcome, about a 7% reduction for cetuximab radiation versus platinum radiation. That was the RTOG 1016 trial, just recently published and presented at ASTRO. So the question is, what is the backbone for adding anti-PD-1? In the RTOG 3504, we had a cetuximab containing arm with nivolumab. Actually, I presented that at ASCO 1 year ago, showing that it's safe. And in fact, if you looked at the RTOG 1016, although platinum was superior, it was really only in the performance status 1 patients. Of the 850, 200 of those were performance status 1. If you look at the other 600, there were performance status 0, very fit, robust patients. Cetuximab performed just as well as cisplatin. So we know we can add immuno-oncology agents on top of either cetuximab or cisplatin. I think that cetuximab as a therapeutic antibody may be a better partner than chemo, but that remains to be seen. Cetuximab is also being added in Europe in some other combinations with other IO agents. Cetuximab has shown activity with a natural killer cell, NKG2A blocker called monalizumab, and I think we have some cetuximab partners that may allow it to be integrated into future trials in head and neck cancer.
And so that segues nicely into the Palatinus trial of looking at palbociclib, the CDK4/6 inhibitor in combination with cetuximab. So what are your thoughts on this poster that's being presented here?
So I think the CDK4/6 inhibitors are quite appealing. That trial was somewhat small, 30-some patients. So I think it's promising and it's a nice new angle. We shouldn't forget that it doesn't just hit the tumor cell, that in fact the CDK4/6 inhibitors may actually be immune stimulatory as well, and appear to shift the myeloid or macrophage populations, and that may allow cetuximab to be more effective from an immunologic standpoint. I should mention also, while we're talking about new findings, the big phase 3 trial called EAGLE, which was durvalumab alone versus chemo versus durvalumab plus CTLA-4 targeting tremelimumab. So that big phase 3 trial showed that durvalumab is active, but for some reason when you added tremelimumab, it didn't perform as well. In fact, it was slightly worse. So we're not sure what to do with tremi at this stage, but durvalumab is another IO agent that appears to be active in head and neck cancer.
Okay, something to keep a lookout for?
Yes.
Good. So what else can we expect over the next year in head and neck cancer, and what is the future of this disease, the treatment for it really look like to you?
Well, we've completed a phase 3 trial called Javelin 100, which was adding avelumab to concurrent chemoradiation, that follow-on of the RTOG 3504 that Dr. Gillison, my colleague, presented at this ASCO. And so we now want to see the results in terms of oncologic benefit. That was about a 600-person trial. So that should hopefully get IO approved in the locally advanced setting if it's positive and better than chemoradiation alone. Also, a number of combinations are coming up, small molecules, the TKIs plus IO, such as sorafenib and lenvatinib. Then the CDK4/6 inhibitors, we'd like to see those combined with IO. So a lot of great things happening. We just need to make sure we don't get so excited about the 30-person, phase 1 trials, that we still need to test them, but in really a more rapid fashion, such as neoadjuvant therapy.
Great. Dr. Ferris, you made some really great points today, and thank you so much for sharing your insight on the head and neck cancer landscape and everything that's to come.
My pleasure. Thanks for inviting me.
Sure. That's all for today. Stay tuned for tomorrow's OncLive News Network On Location, where we will sit down with Dr. Shubham Pant of the University of Texas MD Anderson Cancer Center on gastrointestinal cancer studies, and Dr. Scott Tagawa of Weill Cornell Medical School, New York Presbyterian Hospital on pivotal prostate cancer abstracts. And don't forget, the OncLive Global Expo is taking place October 11th through 13th in Orlando, Florida. Join us for a fully interactive meeting that brings together the most inclusive group of oncology professionals to collaborate on emerging trends and technologies in oncology care and research. Thank you for watching OncLive News Network. I'm Gina Columbus.